Bienvenido, doctor Recharé.
Thank you. Good morning, good afternoon, good evening to everybody along and across the world. Welcome to this international seminar on engineering contributions for managing the next pandemics. It is not keen to say that pandemics is a big problem and that we are suffering now something that we didn't see for a long time. Most of the attention is paid, we see every day, on the biological aspects of the pandemics. This is biologists and medical doctors, and it is focused only as a problem of health. So we have decided to organize this seminar to pay attention on the contributions of engineering. This seminar is organized by the Committee on Disaster Risk Management of the World Federation of Engineering Organizations. We have now 3 speakers and 2 people in panel to comment. And to open the seminar, I would like to invite Dr. Carlos Herrera, who is the president of the Peruvian Association of Engineers. So, Ingeniero Herrera, please. Your microphone is off, Carlos.
Okay. So, good afternoon, good evening, good night, probably, everybody. Greeting you from Lima, Peru. I'm speaking on behalf of the Peruvian Engineers Association that, together with WFEU, is organizing this event. I thank, first of all, to the organizers, speakers, and you, the participants, who made it possible for us to see and hear in the next few minutes 3 very interesting presentations about the experience of the recent participation of engineering and, of course, of engineers in the fight against the pandemic caused by COVID-19. All of this within the framework of the WFEU committee to reduce the risk of disasters caused by natural phenomena. From my own experience during this period of fighting of what happened in Peru, I had become very clear that the support provided by engineers can be very decisive in obtaining a good result, even when this is not the situation of my own country. And basically, I understood that a hospital is a technological complex which is on his basis managed by engineers, and at the end and final front is acted by medical people, by nurses, and all the people related with the fighting against the COVID. So I welcome everybody to this event, and I'm certain that we will gain a lot of this. Thank you very much.
Thank you very much, Ingeniero Herrera. We go straight forward to the presentations that is the important today. The I present the first talk with the title of Early Warning Systems for Pandemics, Lessons Learned from Natural Hazard. That would be presented by Dr. Karina Fernley. Karina is an associate professor of science and technology studies at University College of London. She is an interdisciplinary research, drawing on relevant expertise in social sciences, on scientific uncertainty, risk, and complexity, to focus how natural hazard early warning system can be made more effective, specifically alert level systems. She also has interest in the transdisciplinary potential of art and science collaborations around the environmental hazards. Karina established the World Organization on Volcano Observatories, Volcano Alert Level Working Group, and edited the first publication dedicated to volcanic crisis communication, called Observing the Volcano World, Volcanic Crisis Communication. In 2020, she founded the UCL Warning Research Center, that the world's only center dedicated to international research and collaboration with stakeholders to devise better warning for all hazards. So, Karina, the floor is yours for your presentation. Welcome.
Thank you and good afternoon, everyone. I will attempt to share my slides to you now, so hopefully that is working okay. I'm very delighted to be invited to speak today, and what I would like to do is to go to the next slide. I will be presenting 4 different aspects of my talk, which will be to give a little bit of background around pandemics and warning systems. And then I'm going to explore 2 key questions about how can other natural hazards help devise an effective pandemic early warning system. And then I'm going to look at how we might have effective COVID alert level systems, which many of us are using on a daily basis. And then to summarize what we can take from that to develop better pandemic warnings. So we know disease pandemics and disease epidemics actually have a very high mortality rate. Actually, 6 of the 38 most deadliest environmental disasters were due to epidemic diseases, and they account for 30% of the fatalities recorded. So these events don't happen very often, but when they do, they are incredibly significantly very large killers, as we are experiencing right now. And you can see on the slide a history of pandemics and the associated death tolls from those. And what's interesting is that an epidemic or a pandemic is somewhat different to other hazards. Normally, we like to evacuate or move away from a danger zone, but with a pandemic, we're asked to stay put and not go anywhere or interact with people. And so it's a very different type of hazard for us to manage. And it's a very difficult issue because quite often, well, it's very difficult to determine when a new health crisis is emerged. And usually by the time that's been established, it's too late. It's already began to spread around the globe, and so it becomes somewhat uncontrollable. And that's one of the key challenges, is really not being able to predict or forecast these things very, very well. But it was something that was anticipated. We have had warnings over many reports in recent years. As Mami Mizutori, head of the United Nations Disaster Risk Reduction Group, stated that past warnings of pandemics were often ignored despite the mounting evidence. And we've seen many reports highlighting, a very real threat of a rapidly moving, highly lethal pandemic of a respiratory pathogen that could kill 50 to 80 million people and wipe out nearly 5% of the world's economy. So the epidemic, the pandemic that we're experiencing right now shouldn't really be a surprise to us, unfortunately. And perhaps one of the reasons is we haven't heard the warnings that have been issued. Now, warning systems are not just a simple siren that states we need to move. It's actually a much bigger, complex assemblage of different people, protocols, and plans. And a recent definition by the United Nations states it as an integrated system of hazard monitoring, forecasting and prediction, disaster risk assessment, communication and preparedness activity systems and processes that enable an individual, community, government, business and others to take timely action, this is the key thing, timely action, to reduce disaster risks in advance of a hazardous event. And so they bring together, by their very nature, many, many different experts, and they have all sorts of thresholds by their natures to when we want to issue a warning, and they have to communicate that to a very diverse user group. In terms of current pandemic early warning systems, the World Health Organization issued or set up this network, the Global Outbreak and Alert Response Network, in 2000 to help identify specifically these unusual agents and start to set the system in place for something unusual being detected, and we should raise awareness for that. But these protocols can vary in their local implementation, and quite often this system doesn't engage with individual nations' actual alert systems or warning systems, and therefore the information doesn't get out there. And so what we can see from COVID-19 is a real need to develop better warning systems for epidemics and pandemics. And what we've learned lots of things. We've had SARS, we've had Ebola, we've had influenza, and we have learned lessons from those events in recent 20 years. And indeed, there are key questions that still remain about the science, about looking at surveying for these emergent new viruses, the difficulty of testing and the large-scale implementation of them, and of course the vaccines, which we're all delighted to hear the good news about at the moment. But also there's questions around basic healthcare in terms of being able to trace those people who are infected, quarantine them, and provide basic care to treat people, or sometimes very sophisticated care that's required. And also integrating beyond the health sector into global coordination and response. You know, this is a disaster, and it needs a much bigger mobilization. And of course, low-income countries, some have actually done very well in terms of managing COVID-19 because they have historical memories of infectious diseases, and are better equipped to deal with those because they've had experience more recently. But often we find that they don't have the resources and expertise to be able to do the things that they wish to do. So we need to take on board the international partnerships that are required to develop outbreaks more easily. So what can we learn from other hazards? You know, I spent a lot of this year thinking that we must not reinvent the wheel. We actually have learned a lot about early warning systems for many different hazards, and many of those lessons could be applicable in the context of a virus, although we have to be sympathetic to the particular nuances of a virus or a health hazard. In 2004, the Boxing Day tsunami, as I'm sure many of you will remember, in Indonesia killed over 250,000 people. And this triggered a decade of intensive examination of early warning systems headed by the United Nations. And they produced a report which gave an outline of what they felt a warning system should look like. And you can see here their model is based around risk knowledge, monitoring and warning, dissemination and communication, and response capacity. And this is essentially what is driving all the UN's member nations in terms of devising early warning systems for natural hazards. A colleague of mine, Carolina Garcia, based in Colombia, and I did an evaluation of a number of different disasters from many natural hazards and investigated how effective early warning systems were in recent decades. And whilst we found the UN model to be very useful, we found that failures and successes were highly dependent on the things that you can see in the middle of this circle. So things that are important, such as communication, integrating science research into practice, good governance, preparedness, trust, accountability, responsibility, and so on. And it's these things that link those 4 elements that are absolutely crucial and determine whether a system is successful or not. And of course, an early warning system, as I mentioned before, isn't just a siren. It is an integrated system that has to require a lot of planning between lots of different organizations, cooperation, discussion, education of the public, education of government, education all round of learning each other's different needs and requirements, and preferably simulations and scenarios to run these incidences and see what happens as a result, so that we can be better prepared when the event actually strikes. And so early warning systems are everything from that first mile, right through the science in detecting it, right through to enabling the person on the beach seeing the tsunami coming towards them and being able to respond to it. And that's a very challenging and a very tall order that's required. And it's quite interesting that if we look at health and warning policy, in 2015, and specifically, the United Nations extended the definition of risk to include biological hazards into the Sendai framework for disaster risk reduction, which specifically has one target of 7 to access the availability, increase the availability and access of multi-hazard early warning systems. But it's interesting because if we actually look at reports that have been issued by health organizations such as the WHO or various working groups on health, only 2 times was the word warning mentioned in these reports. And so therefore there has to be a question about the awareness or the ability to integrate warning systems into the health sector and learn from other hazards. There's so much to be learned, and to create a dialogue, we need to share our insights. So I want to present to you 3 of the key findings from my own research that I think are quite important for us to consider in developing a robust early warning system. So in this table here, what I'm saying is it's very important that we create credibility and relevancy between different stakeholders. So on the right, you can see what is the science domain. So that's the scientists who are constantly trying to make sure that their science is robust and accurate. And on the other side, we have the policy domain. So that's those folks in government or federal agencies such as civil defense, police, but also media and the public as well. And so these 2 sides are having to come together to try and manage a crisis in a warning system. And they use lots of different tools. So ideally, before a crisis, we would have coordination plans and protocols and procedures and national policy and laws in place that help establish responsibilities and accountabilities and so on. And then we have a number of different communication tools, and sometimes scientists will issue an alert, like a volcano alert will be issued from an observatory, and that information would just be picked up by the policy folk who will then act on it. And sometimes we need to have an exchange of information between the scientists and emergency managers in particular, and that can be done using the phone, fax, email, social media increasingly, that creates a dialogue about what's going on rather than it just being a report or an alert level that's issued. And then, of course, in the middle of a crisis, quite often we need to bring all those stakeholders together through meetings and media and workshops and so on to discuss what's going on. And so really what this slide is saying is that by trying to create credibility, trying to create relevance to what's going on, we can make legitimate information, which can then, through these tools, these communication tools, help people to communicate and understand and adapt in a very agile way to a particular crisis. The second key question is, what combinations of texts and icons do we want to use in our warnings? And I've given some examples here, so you can see the New Zealand volcano alert level system uses numbers. We've got the United States Home Loan Security Advisory System that uses a traffic light system, which is very common. Sometimes we use icons that you can see here for different warnings of weather. And at the bottom, you can see alert levels used for volcanoes that uses terminology such as normal, advisory, watch and warning. So these alert level systems are a very particular tool used to communicate in a shorthand way that there's something going on. And that's often quite difficult for scientists to establish and to know when to change alert level. And on their own, alert levels need, they can't achieve everything. They need more information to be issued to make sense of them. And so the design and the criteria that you use to go from different alert levels is different for each nation and each hazard. And there needs to be a lot of learning and shared understanding around what would be best for a pandemic. And then finally, my third sort of key finding is about looking at standardization, because of course with pandemics, there is no respect for international or national borders or politics. And so we have to think carefully about who is benefiting for standardization or not. And for some hazards, that is, a local, more bespoke system is best, but perhaps in the case of pandemics, an international or certainly a national standardized system is better to help everyone better understand what the needs are, how we communicate, and decision-making and management issues can all be understood within a certain framework that's the same for everybody, just simplifies things. So there's a lot to be said about the role of standardization, but there needs to be enough flexibility within that standardization to take into account local needs and local variances, for example, in COVID rates or infection rates and so on. So it's a balance that needs to be achieved. And we can see some of that actually when we look at COVID alert level systems, what makes an effective COVID alert level system. And I repeatedly refer to two case studies, which I'll just briefly present, but many countries have developed alert level systems. Some have had them in place for previous epidemics and pandemics, and some successful nations have included Singapore, Vietnam, South Korea, South Africa, and New Zealand. And we can see the New Zealand alert level system has actually been voted by many surveys as being one of the top response communications for COVID-19. The fact that it was set out very early, it's given great detail about what each level would involve, and it's helped people manage their expectations of what their future might look like. And this system is very clear, it's very specific in terms of what each alert level allows people to do in different sectors, whether it's a public venue, travel, transport, workplace, education. And in doing so, it has created significant credibility, accountability, and transparency with the public. And that's been a great success. And this is the system that you can download online, and you can see very, very clear, very, very nice example there. In contrast, perhaps, dare I say, the UK COVID alert level system has been a little bit more haphazard. In May the 10th, after about 3 months of having COVID as a significant problem, our Prime Minister introduced a national COVID alert level, but then actually in October this was then revised into a locally bespoke alert system that has 3 tiers. And of course in the UK we have challenges because we are a nation of 4 nations, and so England has a standard system, but Scotland, Wales and Northern Ireland have slight variances. And unlike many countries, we haven't had a very strong voice from our civil protection experts. And consequently, there's been a lot of confusion about the alert levels and what you can and can't do, and a lack of transparency. And this has really led to a lot of different problems, but really perhaps a lot of loss of credibility in the UK. And so I list here 10 lessons for pandemic early alert level systems. And really, it's very simple things: transparency, credibility, tying your alert levels to specific actions so people know exactly what they need to do in a specific alert level. Moving away from a homeland security approach to more of an alert level system that's designed for the public to work together as a community to eliminate the virus. And being very clear about what the criterion are for different alert levels, being clear in terms of engaging from top government right down to the local level, local authorities, and making sure you have a very good communication and public engagement and scientific communication program in place to inform the public, inform different actors, and reduce confusion. And finally, is important is to enforce the rules that you have. Otherwise, they are very easy to break otherwise. So to sum up, which I'll do in the last couple of minutes, I guess I just want to leave you with two key thoughts. One of which is, in many countries, and the UK in particular, there's been a very big dominance of science, and unfortunately science is only part of the answer. I present to you here post-normal science, which is a framework used in science and technology studies when facts are uncertain, values are in dispute, stakes are high, and decisions are urgent, which of course we find the case of many natural hazards. And what Funkchevez and Ravitz say in their framework is essentially that we need to be talking to each other through an extended dialogue with different communities about the uncertainties, about the ignorances involved, to try and come to solutions, because the science can't just give us the answer. It doesn't always have the answer. And really that's what my sort of takeaway point is that we need to make sure that we are having lots of conversations. And as part of those conversations, we need to do a very deep forensic analysis of the crisis that has just happened and look at what's happened on a local and a global scale. Look to early warning systems and alert level systems during this crisis across all the nations, and try and think about how cross-border standardized systems could and should be put into place, and review those successful systems and those that have failed as well, to try and identify what are good practices. So to finish, I think there's an importance here that we can learn from natural hazards, other natural hazards such as volcanoes, tsunamis, earthquakes, weather, and so on, which is to make sure we integrate credible, relevant, and legitimate data as part of the science and policy interface, and that's really important. That we have a range of tools of communication that work in many different directions that involve a lot of dialogue and help in the decision-making processes, and that we invest in preparedness. So important that we are prepared for these events. We do not have time when they strike to have conversations about reinventing the wheel. We need to be pulling the plans off the shelf and getting going. And then finally, really about devising stronger and more robust early warning systems and alert level systems, both nationally and internationally, particularly using the expertise and the reach of the World Health Organization, and drawing on well-established systems that they run and that exist for other hazards. And I hope very much that that will then put us in good stead for the next pandemic, which will happen. Hopefully we won't see it for a long time, but it will happen. And so finally, I just would like to flag the warning centre that I've established, and I very much hope that this warning centre will become a centre of focus for this type of research going forward, where we can share these best practices and hopefully next time round do a better job, because it's not just lessons identified, we need to make sure it's lessons learned. So thank you very much. Jose, sorry, Dr. Jose, I think you're on mute, sorry.
Yes, okay. Excuse me, I forgot to open my microphone. Karina, thank you very much for your talk. Maybe it's important now to think for everybody how to approach to each other the um, epidemiological community that is always looking at the evolution of this kind of process, and the risk management community that has quite different processes. And I think we need to join both of them. Please stay with us, and I hope it's not too late for you. Before continue, thank you again. Before continue, I have to say for people in the room that want to make any question or comment, you can do it by the chat button of the system. Okay, we will take the question from there to translate it to the speakers. Now we continue with the second talk. We welcome Dr. Ximiao Chen. Dr. Chen is a visiting professor at the Chinese Academy of Medical Sciences and the Peking Union of Medical College in China. The head of research unit for health and population economics at Heidelberg Institute of Global Health at Heidelberg University in Germany, and is an Alexander von Humboldt Research Fellow. Her primary areas of research include population health, health economics, aging, health systems, and health policy, mainly focusing on the public health emergency response policies. Also to the interrelations between health status and economic growth. Also the impact of policies on health and economic development. And finally, the social determinants of health. She has published more than 30 articles in renowned journals such as Lancet, GMEM, JMA, BMJ, Lancet Planetary Health, Science Translational Medicine, Health Affairs, and others. Ximiao also was a consultant for the World Bank, for the Pan American Health Organization, the Chinese Academy of Engineering and Population Council in Pakistan. She received her bachelor degrees in industrial engineering from Tsinghua University, her master's degree in management science from Columbia University, and the doctorate in population health economics from Harvard University. She is going to present us the Fankan Shelter Hospital, a novel concept for responding to public health emergency. Please, Ximiao, it's yours.
Yeah, thank you so much for the very detailed, nice introduction. I feel very honored to be here and to present today. Fankan Shelter Hospital is a novel concept that was introduced and proposed in China back in early February, because we know that China actually fighted this pandemic as the first country. And it's a novel concept, actually, in fact, that in the human history of fighting pandemics, it's a novel concept proposed for the first time. And so I think it's a very important concept and for responding to public health emergencies, and is also a key component to support the success of the fight against coronavirus in China. And I will introduce three parts. The first, I will introduce the background. Why do we need Fangtang Shelter hospitals in the first place? And second, the detailed conceptualization of Fangtang Shelter hospitals. And the third is the impact of Fangtang Shelter hospitals. So why do we need Fangtang Shelter hospitals? And this is the current pandemic situation. We see that the Americas and Europe have the largest share of the COVID-19 infections. In contrast, the Western Pacific countries do a pretty good job. And these include China, South Korea, Singapore, and Vietnam. And actually, they all use the concept of Fangtang Shelter Hospital, which is the facility-based isolation for mild cases. And many countries with are facing severe situations. The countries like US, the cases are surging, the death mounting, and hospitals are running out of beds, and the health systems are on the brink. In fact, Wuhan, which is a city in China, the virus was first detected in Wuhan, and Wuhan faced the same problems in early February. And this is a picture showing the condition in early February and late January in Wuhan. It's very crowded, and the cases are surging rapidly, and hospital beds are in severe shortage. And so why is that the case? And the governors and the experts in China, they did some work, and they found that one issue was that in late January and early February, the mild cases, the COVID-19 mild cases are isolated at home. However, these people are really high risk, and they can transmit the virus easily to their household members and to their community members. And so home isolation for mild cases is undesirable because first, it can put patients' family members at risk. And in China, 75 to 80% of all cluster infections are within families. Second, it can put community members at risk because like if you encourage people to self-isolate at home, just like the United States did and many Western countries did, it's not strictly enforced, and many people with mild cases or even asymptomatic, and they may go outside and maybe go to the supermarkets, and they put their community members at risk because the virus can stay on the surface for many hours. And even if they don't contact directly, if the patients left some virus on the surface on some goods, and then their community members may get infected. And the third disadvantage is that it makes medical care, frequent monitoring of disease progression, and timely referral to hospital care difficult to organize. We know that the mild cases are not definitely like infinitely mild. Some cases may actually deteriorate after some time. And if they were isolated at homes, it may not be good because they need to go to the designated hospitals again, and to wait in queue, and it may delay their treatment. And so that's why the Fangtang Shelter Hospital came at this critical point. And it actually gives a place of facility-based isolation approach alternative to the home-based isolation, which was previously used in Wuhan in early February. And this is a picture of the Fangtang Shelter Hospital. And it was originally used as a gymnasium, and then it was converted to a facility of healthcare facility, aiming to isolate the mild COVID-19 cases, and also serve the triage function and provide them with basic medical care and also monitoring them closely. If they have their condition worsen or deteriorate, they can be rapidly transferred to traditional designated hospitals. And then it also serves the functions of like, it's kind of like community feeling, and people are living in Fangcang Shadow hospitals and they have their activities every day. So Fangcang, this term is a traditional Chinese term, and it's similar. It sounds similar in Chinese. It sounds similar to Noah's Ark. So we say Fangcang implies hope for patients. So essentially, Fangcang Shadow Hospital, the concept is using facility-based isolation rather than home-based isolation for mild COVID-19 cases to cut off the transmission chain and protect their family members and community members. Yeah, and so this is the concept. And here, this is the layout of one of the Fangcang Shadow hospitals that were built in Wuhan in February. And from the engineering side, it's quite easy to convert a hospital, convert an existing public infrastructure to Fangcang Shadow Hospital. We just by installing beds and sheltered places, and also the 3 zones and 2 passages of hospital isolation wards in existing public facilities. So 3 zones means the contaminated zone where the patients live, and a semi-clean zone where the health workers, and they take on and take off their clothes, and the clean zone, which there's no risk of getting infected. It's just clean zone like other places. And 2 passages means the passage for patients and the passage for health workers. Because in this way, we can protect the health workers, and also the 3 zones and 2 passages was strictly designed and follow the rule of hospital isolation wards to prevent nosocomial infection in Fangcang Shadow hospitals. And this figure shows the 3 characteristics and 5 functions of Fangcang Shadow hospitals. The first characteristic is rapid construction, because Fangcang Shadow hospitals leverage existing public facilities like stadiums, gyms, exhibition centers. So it's really quick in terms of building, comparing to you build a temporary house facility out of nowhere. So so it's really quick in terms of building time. On average, the building time about within 12 to 24 hours. So it's very important when an epidemic emerges, because there's so many cases surging every day. And the second characteristic is massive scale. It can provide thousands of beds. And the third characteristic is low cost. First, the investment cost is low because it leveraged existing public facilities. So the investment cost is low. And once the pandemic is over, they can be converted back to their original function. And then the operating cost is also low because these are mild cases, and many of them can take care of themselves. So we don't need intensive treatment and human resources comparing to those in a designated or traditional hospital. So the ratio of health workers to patients is quite low. And it has 5 functions. It serves 5 functions, all very important. The most important ones are isolation and triage. The isolation, the major function of this Fangcang Shadow Hospital is to serve because it's facility-based isolation, and it cut off the transmission route between the mild cases and other household members and community members. So that's the first function, to isolate. And the second function is triage. It's also very important. During a pandemic, it actually reconstructed the health system during a pandemic. Previously, all COVID-19 cases are treated in hospitals, but this, like, if you built the Fangcang Shadow Hospital in the community level, it actually linked the home to a hospital. to a traditional hospital. And the COVID-19 patients with severe to critical disease will be admitted and isolated and treated in a traditional hospital, while the mild to moderate COVID-19 cases will be admitted, isolated, and treated in a Fangchang shared hospital at a community level. And the third function is basic medical care. So in Fangchang shared hospital, because some people, even though they are mild, their symptoms are mild, they still have fever and some kind of symptoms like diarrhea, etc. So they can be provided with some drugs, basic drugs like antiviral, antipyretic, and antibiotic treatment. And fourth function is frequent monitoring and rapid referral. Once their conditions worsen, they can be transmitted. First, they can be identified timely because they can be monitored every day. And so we can identify the early onset of symptoms that may lead to severe cases. And then if their condition worsen, they will be transmitted directly through a smooth channel to a designated hospital. And the first function is essential living and social engagement, because many people live there, those patients live there. So we can provide like entertainment and book corners, snack corners, etc. So to make them feel that this place is like home. And I would like to stress again the strategic triage function of Fangchang shared hospitals. It actually reconstructed the health system during an emergency. Like this is an emergency of pandemic, but in the future, if there's another emergency like to cause injury, we can still think about this kind of triage system if there are large or massive injuries, and people can like mild injuries. And here in this case, mild cases are in Fangchang shared hospitals. It added another layer. It inserted an additional level of care into the health system, and it connects the community level and the designated hospital level. And people who identified mild, they can refer from the community level to Fangchang shared hospital. And if their condition worsens, they can be referred to the designated hospital level. And it actually not only good, it's not only good for controlling the epidemic, it's also very important for releasing the pressure on designated hospitals. And you know that many deaths, it's not only can prevent infections, it can also prevent death, because it actually released the pressure on designated hospitals, so that the designated hospitals have more resources like ICU beds and ventilators, etc., to care for the severely ill and critically ill patients. And that's another important effect of Fangchang shared hospital. And many people may think, oh, Fangchang shared hospital in Wuhan is very similar to emergency field hospital. We know this concept before, but actually it's not the same concept. Although nominally, if we see this, it's also converted from existing infrastructure. But if we compare it with the emergency field hospitals in New York, they are actually different because they serve different functions. And the most important thing is functions. And the emergency field hospital in New York, they admit non-COVID-19 patients initially, and then they found they're barely the non-COVID-19 cases. And so they revised the admission criteria, and they admit patients in COVID-19 patients in recovery, but whatever their admission criteria, they did not serve the function of isolation, cutting off the transmission route, and releasing the pressure of the designated hospitals and the strategic triage function. So they serve different functions. And so we can see that since New York, they don't have the facility-based isolation, and the emergency field hospitals in New York barely admit patients in the end. Then they closed. It costs a lot of money, and then they barely admitted COVID-19 cases. And also we can see that from this chart, there is a high rate of intrafamily transmission in New York. 66% of hospitalized patients are infected at home. So the impact of Fangchang shared hospitals. This is the patient flow in and out of Fangchang hospitals in Wuhan back in February and March. The light blue bar shows the number of patients in Fangchang hospitals. The dark blue bar shows the number of vacant beds in Fangchang hospitals. The light orange bar shows the number of cumulative transfers to higher level designated hospitals. The red bar shows the number of cumulative discharges. And we can see that initially there are so many patients admitted to Fangchang hospitals. And about February 20th and 21st, and the number of patients started to decline because it actually, the pandemic is under control, is nearly under control during that time. And on March 10th, there were no patients in Fangchang hospitals, and they are all discharged. And so the Fangchang hospitals were suspended one by one because they have finished their task. And China then afterwards, it controlled the pandemic. And then we can see the triage function. Here, this shows the number of vacant beds in designated hospitals. And here we opened the first 3 Fangchang hospitals, and here we opened all 16 Fangchang hospitals. The vacant beds in designated hospitals steadily increases. And there are many evaluation empirical studies and modeling studies try to evaluate the impact of Fangchang hospitals in general. We found that it actually reduced the number of infections and mortality, advanced the terminal phase of COVID-19 in China. This actually may have some like social and economic impact because it actually advanced the terminal phase of COVID-19 in China. People are free to move again. And the facility-based isolation and quarantine in Wuhan averted about 70% of infections in total. And because China was the first to fight this pandemic, and afterwards we saw other countries, they also learn from some of the interesting, like insightful strategies to control the epidemic, and the Fangchang hospital was also learned by Singapore and many other countries. And this is the case in Singapore. They established a community care facility, and they said in their paper it's modeled after Fangchang hospitals, and community care facilities in Singapore have provided 3,200 beds and admitted a total of 3,758 patients. And there's another paper simulation study found that a reduction of almost 60% of infections throughout the epidemic is a simple simulation study, but it concludes that facility, not home-based isolation, could control the epidemic. And this is in the setting of Singapore. And this is another paper that we did, another research that we did, and we also adopt this Fangchang hospital concept in the United States. We see if, what if United States adopted the facility-based isolation rather than people are self-isolating at homes. And we found that US could avert millions of infections and thousands of deaths by isolating mild cases in facilities rather than at homes. And maybe this chart can show better the impact of facility-based isolation of mild cases will be boosted by expanded testing. This is number of infections averted due to facility-based isolation. And this shows the different levels of facility-based isolation capacity. And here, 10 per 10,000 population is the capacity of the Fangchang hospitals in Wuhan, China. And so if we modeled, if US established Fangchang hospital home facility-based isolation with the capacity level as Wuhan had, then it can avert 76% of infections by expanded testing, accompanied with expanded testing. And also the Fangchang hospitals concept was adopted in WHO guideline, and they cited us and also developed the guideline for other countries who want to repurpose facilities for isolation and management for mild case COVID-19 cases. So it's a good starting point if any country want to know more about this idea. And also there are many other editorials in Lancet and BMJ talk about this concept because this was like the first novel concept that was proposed in human history, because COVID-19 has its own characteristics. The mild cases are transmitting the virus very quick and has very high infections. Thank you so much, and really appreciate presenting this great conference. Thank you.
Thank you very much, Dr. Cheng. Very interesting talk. I think there will be some questions there. I would ask, please, our speakers to have a look to the chat column. There are some questions that you may answer in the second round. Okay, thank you very much. We now we welcome Michael O'Sullivan for the third talk. Mike is a senior lecturer in the Department of Engineering Science. He has a bachelor degree with honors in mathematics and computer science, and masters with distinctions in operation research from the University of Auckland, and a master in science in engineering economic systems, also in operation research. And finally, a PhD in management science and engineering from Stanford University. Mike is co-founder of the and also co-director of the Operation Research Union Analytics. It's a research group which combines operation research and analytics to develop intelligent systems. Oriwa works on research projects from multiple industries, including healthcare, information and communication technologies, infrastructure planning, construction, logistics, and government policy. He is very motivated to see research used in practice, and has co-founded two companies, Amino, that is developing next generation computing infrastructure, and Oriwa, that I mentioned before, that provides big data analysis for precision-driven healthcare in China. He also recognizes that collaboration is a key to research innovation, and is a theme leader in the precision-driven healthcare research partnership and associate investigator in the Te Punaha Matatini, the Complex Systems Center and Research Excellence in New Zealand. So, Mike, we are ready to to hear your presentation, please.
Great, thank you very much, Jose. And thanks also for the opportunity to speak to you all. So I'm going to talk today about some work that I've been doing, but also summarize some of the work from other researchers in New Zealand, particularly from Te Punaha Matatini, which is a Centre of Research Excellence in New Zealand on complex systems. And this is about the healthcare modelling for the pandemic planning in New Zealand, and more recently to help recover from the pandemic as the number of cases in New Zealand have dropped. One second. So just a quick introduction to myself. Ko mona kia te mauna, ko waitamata te moana, ko waka moana te waka, ko te aratu te marae, ko arangi me haina te iwi, ko a Sullivan te hapu, ko mai aho. So that's just Māori pepeha, which is an introduction to me and where I'm from and my family. And then you'll see on the right a little bit more about my background, which Jose gave you most of that too. So I'll just skip over that just to say that I do a lot of research and consulting and operations research and analytics, but particularly with mathematical modeling embedded behind everything for in lots of different areas, including healthcare. And so the work I'm going to present today was a collaboration with Associate Professor Ilse Edens from the Statistics Department and a good friend and co-director, Associate Professor Cameron Walker from the Engineering Science Department. We're all part of Te Pūnaha Matatini, and we got involved in the response quite early, looking into some of the disease spread models from another group I'll talk about shortly, and how that translated into hospital and ICU admissions, to look to see if how that surge, which I was talking about, would affect the New Zealand health system. And the reason that we were asked to do this is we've been working with the district health boards who run the hospitals and the healthcare system here in New Zealand on a bunch of different things, including surgery scheduling, ICU planning, etc. And I'll talk a little bit about some of those in terms of the recovery later. So this is the frontline team from Te Pūnaha Matatini. So they did the first models around COVID spread in New Zealand, and they were having weekly stand-ups with the New Zealand government to help inform what the best response to COVID-19 was. And so we went into a lockdown in March, and part of the reason for that lockdown was this initial modelling from this team of people. And I'll talk a little bit about their model, and I'll talk a little bit about how it's evolved later on in the talk. This is the bigger team of people. So some of the work I talk about is also dealt with here. I want to pay particular attention to the first person at the list, Susie Wiles, who's a microbiologist, I believe. And so she's been amazing in terms of communicating what the various alert levels mean and why they're important, and washing your hands and wearing masks and all that, and all those sort of things for helping stopping spread. And so her and Sean Hindi from the previous slide there, a second to the right, have been really amazing at communicating the science, and so that the policy can be understood by people in New Zealand. And I think that sort of communication, and Karina talked about it, has been so key, and that transparency has been really key in New Zealand, following some of those alert level rules, and has helped a lot in the by and large elimination of COVID in New Zealand. So as a background, New Zealand followed a policy of go hard and go early, and this decision was with the aim to eliminate COVID-19 in New Zealand. We've had just over 2,000 confirmed and probable cases, and of those cases, really only a small number are hospitalised, and even less who actually entered the ICU. And the work I'm talking about, as I said, was part of a very large team, which was led by Sean Hindi, and started looking at patient flow models. And the nice thing was that the detailed patient flow models actually turned out not to be needed in New Zealand. I'll talk about that coming up. So here's what the initial model looked like. It's a relatively simple SEIR model where we have susceptible people on the left, and then once they are exposed to the virus, they have a short exposed period and they enter a pre-symptomatic period, which is where they're infectious but not showing any symptoms. Before then, there's a couple of infected I1 and I2, a couple of infected states, and then either they recover, or if things don't go well, they become deceased. And so this simple model was actually what was used to look at the initial effect of COVID-19 in New Zealand. And this model showed that if the New Zealand government didn't do anything, that the number of deaths in New Zealand was, in the tens of thousands. And so that was part of the reason behind the New Zealand government decided to lock down early. And where Cameron and Ilse and I came in was to take this model and extend it into stays in hospital. So you can see the pre-symptomatic and the infected and the recovered states at the top there, but also we have the initial stay in the ward, which is where you're infected, but your situation becomes serious enough, you need to be admitted to hospital. Then you may recover, or you may get so serious you need to go to an ICU. And then also from an ICU, you may get better enough that you can then transfer back to the ward and then recover, or in any of those situations, if things don't go well, you may become deceased. And so we were looking at how the number of people in the pre-symptomatic and the infected 1 and infected 2 states translates into number of people in the wards in the ICU, and then looking to see what that meant in terms of the New Zealand health system, and did we have enough beds, and particularly did we have enough ICU beds. And so this is an example of the output of some of the models. So each one of the slightly lighter traces with markers on is a simulation. So there's 10 simulation runs, and these pink lines are the simulation of the total number of infected people, which is the sum of the this purple and I'm going to say brownish line here, which is the I1 and the I2 respectively. And then the actual number of infected is this dashed line. So you can see here we've got a reasonable match, not a perfect one, but a reasonable match. And then the green is recovered. And more importantly for the work we were looking at is down the bottom, you can see there's the cyan lines here, which is the number of people in the wards and hospital, and then the magenta line, which is the number of people who have been admitted to the ICU. So by looking at these, the government could make calls on policy to try and reduce the impact on the health system. And you can see the blue shaded region is actually the first lockdown, which lasted, I think, 6 weeks. And that was a level 4 lockdown where everyone was expected to stay in their homes, except for one person who was allowed to go and get groceries, and everyone was wearing masks. And then the pink zone, I think, was level 3, which meant that more of the number of essential services was increased, so more people could start doing their daily operations, and you allow a little bit more freedom to move around and buy food and that sort of thing. And luckily we're well out of those now. And this is just a close-up to see what happened in the health system. So you can see here again, the dashed line is the actual ward admissions, and then the blue, all the other cyan lines are the simulations, and then we have the ICU down here. So certainly early on, the match is quite good. Although if I go back one side, you can see that the simulations were well above what happened in actuality. So the simulations are probably in some ways a little bit pessimistic. So that was one way that our mathematical modelling helped inform the pandemic response. Once we had the basic model about how transmission in the community would lead to admissions to hospital and load in the wards and ICU, we started looking at what would happen if the healthcare workers who were then exposed to COVID-19 patients also became ill. And so it was something that Cameron looked at. We also started looking a little bit at geographic spread, and I'll talk more about that in a minute. And that's actually progressed even further with some other researchers from Te Puna Matatini. And there's also different models. So the SCI model is a relatively straightforward one. And there's some other models that Sean Hendy and co developed, and I'll talk about those shortly also. So effectively the pathway looked at taking these inputs from this part of the model and then translating them into whether they moved into Ward 1 and then ICU in Ward 2 and recovered, or maybe go to Ward 1 and recover immediately. And so what we're looking at here is to say there's the resources, there's nursing resources and doctor resources for Ward 1 and ICU in Ward 2, in particular, it's the number of beds. But what happens if the healthcare workers start becoming ill and then they have to isolate, and that means now there's a higher ratio of patients to staff, and so it's more likely of becoming ill, and the whole thing can snowball until suddenly, even if you have the ICU beds, you don't have the staff in order to care for patients in those beds. And so the plot on the right here is this is a plot of the models for actually staff members. And so we looked at the 5 pathways through the hospital system, and then at each day, both ward and ICU staff could contract COVID-19 based on the number of patients that are occupying their particular facility. And the staff following the infection cycle the bed availability drops. And once the bed availability drops, then that means less people could go to the ICU. So more serious people have to be cared for in the wards, and some people maybe can't get into the wards. And so the number of fatalities increases. And so that was that sort of modeling was particularly important to assess not only the people coming into the health system, but what is the effect on healthcare workers of large numbers of people coming into the health system. So this also helped inform the New Zealand government policies in response to the pandemic. So this next picture is sort of the second generation model out in the community. So Alex James, Mike Plank, Michelle Binney, Sean Hendy, Audrey Lustig, and Nick Stein. This is their second generation after the SEIR model, and it's a stochastic model that uses branching. And mostly I just want to show the slide to see that, again, they were showing different scenarios to government. So if there was no lockdown, what would happen? You can see the new cases would surge, but by keeping the lockdown going for a reasonable amount of time, then we keep the transmission number R down to 0.65 and keep the reported cases low. And the nice thing is you can see there that their models are really well calibrated. So what their models show matches quite a lot of actually happened. And that gave government a lot of faith in the science. And so then they would try, so they would ask Sean and his team to run lots of different scenarios of what if this happened, what if this happened, what if we did this policy, and they would have a lot of faith that the answers coming out of the science would reflect what was going to happen in real life, and that gave them a lot of certainty in going forward with their policy to fight the pandemic. So this next part was looking at a smaller area in Auckland, and this was really looking at how COVID-19 spreads through an area, and particularly what was interesting here was that, so I split up a larger part of Auckland, which has about 500,000 people, into smaller areas called mesh blocks, which are sort of, in a city is generally a couple of city blocks. And I assumed that in each mesh block, we just had everyone was considered the same, but across the mesh blocks, because there were restrictions between connections, which were due to the various policies of control. And so people would only connect if they, under the lockdown, people could only potentially transmit between mesh blocks if they shared a supermarket or a petrol station or a health facility. And so you then look at looking at what's the effect of limiting people to stay in their home. And as you change your policy, then you can allow more interaction between the mesh blocks, and you start seeing more transmission of disease between areas as the government policies on resting in place or how much you're allowed to move around change. And so the interesting thing with this one is, so there was, we allowed one person who was exposed, they weren't even pre-symptomatic or infectious in the area. And so you can see that that's one little bar, and then allowed the disease to progress. And we ran 10 replications, and of those, 5 of them, nothing happened. And so you can see here after 3 weeks, there's been a little bit of spread in a few places. After 6 weeks, again, there's a bit more spread, particularly in the top right. And so if we watch the disease progress over 100, and then 200, and then 296 days. So you can see in half the scenarios, there was no spread of the disease, but for half the scenarios it was. And I think that shows just how infectious COVID-19 is. And I recognize that's conditional on the parameters of the model. But what this allows you to then do is allows you to look at targeted testing in high density areas, and look at how can you pick up, so this kind of goes to what you were talking about, Karina, can you pick up the disease early by testing in the right places? And actually this work now has progressed to a multi-layer network model done by led by Dion O'Neill and his team, where they're now modeling every single person in New Zealand as a node in the network, and they have different networks which determine how these people interact, with their contacts are, how the disease is spreading, and even how they are reacting to various policies. And so one of the things that we've been able to do with this is look at contact tracing in one of the most recent outbreaks in Auckland, which luckily was contained relatively quickly with a short lockdown period. and I suppose we're lucky in New Zealand, we've only got 5 million people, but it still requires some pretty heavy lifting computationally to be able to do this. But it means that they can really lock in, and you can get very strategic about how you are doing testing and where you implement your policies. So now you can have different policies in different regions, I suppose, similar to how London is going to lockdown, whereas the rest of the UK is less so. And this gives you a model where you can try those kind of things and react to the pandemic in a local way while still being informed globally, or at least nationally, what's going on. So the nicest thing was for the work that Cameron and Ilse and I did is that the models weren't needed. Luckily, the number of ICU beds, even though it was relatively low in New Zealand, never got much above 5, and also the ward wasn't overwhelmed. So it was a really interesting and quite frantic time, but we're really happy that our models actually weren't used, although, as I said, the models of Sean Hendy and Co have been really key in informing New Zealand's response to the pandemic. So what Cameron, Ilse and I have now moved on to is helping health systems recover from the pandemic. So we're doing some automatic surgery scheduling to help the district health boards plan the elective surgeries to catch back up with the waiting lists of all the surgeries that had to pause during the lockdown. And this is, we're working particularly hard with Nelson Marlborough DHB, and they're about to put the system into their planning, into their overall planning system to try and help them decrease the waiting list. And I should actually say, the first people to use our surgical scheduling was actually a hospital in Ningbo in China. So I'm not sure what they've done during the pandemic, because we've a little bit lost touch over that time. But this is to get to a point I make later. I think this kind of thing doesn't necessarily just need to be for pandemic recovery. One of the other things we're doing is looking at pathways of people through the hospital. So this is a simulation of people using CT scanners, and again looking to help health systems catch back up, but also to add some data-driven and optimization behind some of their decision making and modeling where their patients go, to again try and help them add that intelligence business as usual, but also be able to then catch back up in situations like a pandemic. So the bottom line for me is, I think that that this modelling has been a really useful planning tool for helping New Zealand deal with the pandemic very well. I think it's also very useful not just during the pandemic, but to help recover from the pandemic. And the amazing thing for me was that Sean pulled these teams of people together very quickly, and everyone's pretty much been just giving their time to help fight the pandemic in whichever way they can. And so you saw the big list of people they had earlier. There has been some funding, but initially it was just, can you help? And everyone just jumped on board. And I completely take Karina's point that it would be much nicer if this was all ready beforehand, which is kind of my last point. But also it was pretty amazing what was done in a pretty short period of time. And I think our modelling has been really key in helping New Zealand make a well-informed response to the pandemic. So yeah, that does get to my last. I think a lot of the stuff, particularly the stuff for recovery, actually if that was in place in business as usual, allows healthcare systems to be very resilient and agile and be able to respond more quickly to adverse events like this, but also just to provide healthcare, basically to use data to see if they can just need to tweak how they're providing these services to provide the best healthcare in the case of something like the winter flu and those sorts of things. So thank you very much for listening, and I'm happy to take questions.
Thank you very much. Thank you, Mike. I was anonymous. Thank you very much again, Mike. A great presentation. Thank you for all of our attendants that are in the room, and they following by the Facebook network also. In the room we have, I have to mention 3 of our CDRM members of the Committee of Disaster Risk Management, Dr. Bransdon from New Zealand, Dr. Karel Vancura, hello. Our new member, Valentino Putrino from Italy. Thank you to all of you. Also, we have Dr. Jose Luis Segovia. I hope you have good questions to our speakers, and Dr. Humberto Guerra from the National Academy of Science of Peru. We are now passed to a panel of comments of these presentations. The first one will be by a member of the Committee on Disaster Risk Management too. So I leave you with you to Dr. Engineer Marcial Rivera. Marcial, please, it's yours.
Don Jose, thank you very much. First of all, I want to start by thanking the Peruvian Engineers Association for organizing this activity. I think the timing, the relevance, and shared issues are of vital importance for proper management of the risk that have been generated from the coronavirus pandemic. We have to recognize as a society that COVID-19 exceeded the capacities that our planet had generated for disease containment and care, and our means of communication and transport served for this expansion. Many centuries ago, when our ancestors faced the Black Death and the Spanish flu, among many others, there was the particularity of a slow spread and a concentration of infections in cities or areas. Today's pandemic has had a much faster expansion factor. In the past years, the virus were spread around the world by boat, and today they travel on airplanes. It suddenly took control of our society. The Committee on Disaster Risk Management of the World Federation Engineers Organization is committed to build resilience from lessons learned. I think this is why the participation of Dr. Karina, Dr. Simao, and Dr. Michael bring up the importance of technical basis, which all engineers professionals around the world must incorporate into disaster risk management. The issue that I consider to be cross-cutting to all these lectures and on which I want to focus is the business continuity plan, or also known as continuity of operation planning. In many international certification programs, it is normal to find this topic around ITs or vital networks, and this crisis highlights the importance of the business continuity plan and other crucial aspects of our society. The need to implement business continuity program for hospital, education system, food production chains, transportation system, access to medicines, among many other daily life things, has proven to be a necessity, and COVID-19 made this visible. When speaking about income, for those whose income was not reduced, still they have to face the risk of traveling in public transportation to get their jobs or do their groceries. Moreover, the education system was one of those that faced more complex challenges regarding distance learning systems, particularly in emerging countries where access to the World Wide Web is limited. You probably might think that having access to internet in 2020 is a reality for all people. However, in emerging countries, it is a luxury to find internet access and devices. Something as simple as a computer is not easily available in every household. This has represented an impact in education, as not all students were able to continue at school as they lack the resources to complete the distance learning program. This certainly has created an educational gap that is going to last for many years to be overcome. In engineering, we are used to make long-term projections and make information-based decisions. We need to recognize that many of these models failed to predict the effects of the pandemics, particularly on demand for services. While some services, such as tourism, has been reduced to a zero activity, for example, in countries as Italy and Spain and different tourist hubs around the world, others, such as medical services, face an increasing demand that visibly exceeded their capacity of responsiveness. There has been an imbalance in supply chains. For example, food production oriented to tourism has fallen, while in the other hand, the demand for medical supplies, for example, such as KN95 mask, has increased, exceeding the production capacity. The capacity to expand systems that has been overscaled is a challenge. Let's keep in mind what Dr. Simao told about the importance of keeping a hospital functioning, no matter what. Hospitals not only need healthcare professionals, but they also need medical gases, medicine, COVID PCR testing, drinking water, waste disposal management, among many others. The need chain can be as broad as we want to analyze. The use of technological tools, as Dr. Michael exposed, allows us to make projections in all supply chains to ensure business continuity. As engineers, we must contribute with the most critical condition, which is business continuity. Our society relies heavily on infrastructure and vital networks, which is one way or another are linked to engineer management. Let's keep in mind that a disaster is the result of the interaction of a threat and vulnerability. When the COVID-19 threat is a constant throughout the world, vulnerability reduction management becomes key to reduce the impact of the disaster in our economies. The involvement of engineers in reducing vulnerability plays a key role in the attention of future disasters, which cannot only be derived from health issues such as this pandemic, but also from many other conditions that we share as part of a globalized world. We must recognize that not all countries will be able to build up the same resilience due to economic, political, or geographical conditions. However, we can work on making information accessible to everyone. Today's webinar is a first step towards sharing information in order to build capacity in engineer professionals around the world. And I really appreciate this opportunity because sharing information is a key in the future. Thank you, Jose.
Thank you very much to you. I forgot to say that Marcial is speaking from Costa Rica. Now he is representative of Costa Rica in the committee. Before some questions from the floor, I want to invite our second speaker of the panel, that is the architect Maria Salome Estrada. She's from Peru. She comes from the Association of Engineers and Architects for Hospital or Health Infrastructure. So please, Maria Salome.
Y ahora sí. Bueno, muchas gracias por la invitación a participar en este evento. Yo soy la presidenta de la Asociación de Arquitectos e Ingenieros Hospitalarios del Perú. En primer lugar, agradezco sinceramente las presentaciones de los tres ponentes, de la doctora Karina, de Simiao y de Michelle, que nos han mostrado desde sus experiencias las formas como han manejado sus países estos temas con relación al COVID. En el caso de la doctora Karina, con énfasis en todo el tema de buscar los mecanismos para lograr la alerta temprana. Y en el caso de la doctora Simiao y del doctor Michel, ya relacionado a los efectos y cómo han manejado los efectos del COVID en sus países. En realidad, el COVID, como todos nosotros lo sabemos, el mundo ha sido impactado terriblemente por esta pandemia y nos ha dejado a todos que no estábamos preparados, porque ninguno de los países estaba preparado para enfrentar esta pandemia. Como sabemos nosotros, las pandemias se suceden cada cierto número de años y generalmente un número importante de años. Sin embargo, aun cuando estos son temas epidemiológicos, lamentablemente no han habido, digamos, estrategias o mecanismos que pudieran alertar una situación como esta. Como es el caso del riesgo de desastres, que En este caso, en el tema de riesgo de desastres, ya son muchos años que se viene trabajando en los países, y en Perú se ha trabajado mucho y se ha hecho mucha investigación, y ya se tienen planteamientos, digamos, incluso normativos, ¿no?, que nos dicen cómo debemos funcionar frente a un caso de riesgo de desastres. En el caso de las pandemias, no, lamentablemente. Digamos, en todo el tema relacionado a infraestructura, que es de salud, que es un tema en el que yo soy especialista, nos hemos visto enfrentados a buscar experiencias rápidamente, y cada país se ha planteado sus propias experiencias. En el caso de Wuhan, que han hecho estos centros, como le denominan, FANCA, Italia, España, se han planteado el uso de infraestructuras de equipamiento social de las ciudades, y también han implementado, tal vez con otro funcionamiento distinto al que ha usado China, pero el manejo de los pacientes COVID. En el caso de Perú ha sido diferente, digamos, hemos tenido unos módulos temporales donde se ha hecho el triaje y se ha tenido a los pacientes, digamos, con el COVID leve, y también otras áreas con el COVID ya de más complejo, pero también han habido edificios que se destinaron para solamente los pacientes leves. Sin embargo, un punto que yo rescato de la exposición de la doctora Simiao es de que no se aíslen en la casa, porque en la casa contagian. Y eso creo que es fundamental, ¿no? Aquí y en muchos de nuestros países nos hemos estado aislando en general en la casa, y en la casa contagiando. Entonces, ¿qué esperamos del futuro frente a estas lecciones aprendidas? Efectivamente, considero, al igual que la doctora Karina, que se tiene que establecer todo un mecanismo de investigación para poder determinar estrategias que permitan el trabajo y la identificación de alertas tempranas frente a una situación de pandemia. Si esto lo relaciono yo con los temas de infraestructura hospitalaria, infraestructura sanitaria, ya a nivel internacional, en todos los eventos de arquitectos, se está trabajando en el cómo, digamos, planificar una situación futura de una pandemia. Entonces, ¿qué estamos procurando pensar ahora del futuro de las infraestructuras? Que sean obviamente establecimientos flexibles, que tengan capacidad de adaptarse a las situaciones, ¿no?, que pudieran tener formas un poco más regulares, que tengan algunos espacios como las emergencias, las salas de espera, la capacidad de adaptarse rápidamente a una situación de pandemia, y que también pudiéramos tener identificados algunos espacios del equipamiento social, como son polideportivos, como es el caso de Wuhan, hoteles, estadios, que pudieran estar incluso hasta inventariados y que formen parte de las estrategias de contención de un tema así. Entonces, yo sí creo que este evento marca un hito importante en el inicio de lo que es un trabajo intenso de los países para empezar a investigar, digamos, y acercarnos un poco más para establecer estrategias en todos los campos. En el campo en el que yo me desarrollo, que es el tema de las infraestructuras, estamos trabajando, pero necesitamos relacionarlo con todos los temas que son temas epidemiológicos y temas sanitarios, y creo que tenemos que buscar los puntos de encuentro en los que nos sentemos los especialistas de las distintas ramas para poder plantearnos soluciones a futuro.
Thank you very much, Architect Estrada. We have some questions. Maybe our speakers have already seen some of them. Dr. Alan Moore was asking, Maria Salome, can you turn off your microphone, please? Your microphone. Okay, thank you. Yes, for Karina, Dr. Moore says that we are developing lots of good practice regarding future risk of disaster of a type that come around again in somewhat similar shape. Can we also learn from this experience any useful lessons to apply to the relatively new and even bigger threats of climate change? That is, and Mike asked you at the same time if, so what are your thoughts on the effect of different temporal aspects of natural disasters? For example, earthquake, volcanoes versus pandemics. This is a great deal about this. Put your micro. Okay, thank you.
Sure. Shall I go ahead? Yeah, great question. I think that yes, we can obviously learn from other hazards and could apply that in pandemics, but I think COVID in particular has a lot to teach us. And I think absolutely in terms of climate change, it's a massive lesson learned, partly because the impacts have been global. You know, we do live in an increasing international, interconnected world, whether we like it or not, you know, and so, you know, everything, you know, what happens in my hometown can impact another hometown on the other side of the planet. And so it's really teaching us how interconnected we are and the dependencies that we've developed as part of that process. And so, you know, everything kind of falls down when we can't fly, we can't move around. We saw that through various volcanic ash crises that have grounded planes as well, like in Iceland in 2010. And I think, you know, pandemics have a similarity to climate change in that by the time you've kind of identified there's an issue, it's actually too late. It's already spread. I sort of mentioned this before, and with climate change, it's the same thing. It's actually, you know, it's quite difficult to sort of go to a single point and say, yes, you know, this is definitely, you know, we can outright, you know, you say this, there's no irrefutable evidence that is contradicting this, because clearly scientists will always have their debates about this. But you know, it's kind of like by that point it's too late, and we can see that now. You know, the actions that we've taken in the last 20 years are having irreversible damage on our climate. And so what can we learn? We've learned we need to learn that not only are we globally connected, but everything is connected in terms of our healthcare, our education system, our safety, our security, our sustainability, and being environmentally friendly as well. There was a good question about that. And I think, you know, we've seen this reflection by the United Nations, who developed the sustainability development goals, in basically saying that whatever disaster or hazard we face, we will face it better if we are building better towns, we are building more resilient communities, we are building more environmentally sustainable resources and access to water or food, and making sure that we're planned and prepared for whatever that hazard is. And so we need to build better, we need to be with that eye in the future, and then we're more resilient to climate change, but we're also more resilient to pandemics and earthquakes and whatever, really. So I think, you know, the UN are onto something there, but the biggest challenge is, of course, getting governments to invest money into something that may or may not happen, or, you know, isn't top priority when so many countries are, you know, still requiring a lot of funding in basic healthcare, basic education, and safety. You know, pretty much all nations need a huge amount of money and investment to do that. So it's hard to sort of go, let's take some money away and do something in case something happens in a precautionary way. But of course, when it does happen, like we've seen with COVID, the impact's been absolutely devastating economically, socially, environmentally, all sorts of ways. So there's a lot to learn from this crisis. It's a great question, and I hope that that will be applied in the context of climate change before it's too late.
Thank you very much. It's an interesting question to see meow. Just from Karina, if the concept of the Funcan healthcare existed prior to COVID-19 or not, no? And how this concept can be applied to other nations. And there is an operative questions also for you from Mike, is that what kind of policy is used to test the healthcare workers in the Funcan shelter hospitals? Because someone would think that they are the main risk of transmission back to the community.
Yeah, thank you so much for the very great two questions. And the first question, I think this concept in terms of its novelty, because it had 3 characteristics and 5 functions. So like all these characteristics and functions were not, did not exist before. And it's actually, that's because, for example, this triage function and the community level living, it's kind of like providing a community for the mild patients and to provide them the essential living goods, etc. And so this, like combining all these functions together, it was not proposed before. And for the adoption of this concept in other countries, I think we'd better also think about the specific context of different countries. Like, for example, in China, it's more collectivism, and in many Western countries, like individualism may be per while. And so I would guess if we need to recognize the value of facility-based isolation for mild cases. It's not like to eliminate your freedom, rather it's actually protect your family members, and many people may accept this kind of idea. So it needs communication, effective communication with the public. And then the facility would be different from China, because in China we use like the conversion from large exhibition centers, etc. So there are so many people living together, and also it was also because of the situation back in February, because there's cases surge, so many cases surging each day, and but in other countries maybe there are other ways in terms of facility design, as long as they can fit the function of isolation and triage and medical care and rapid monitoring, rapid referral, and also like this kind of make their lives their living conditions better. So for example, providing more privacies, or the facility could be hotels or other dedicated facilities. Because the major idea here is to use facility-based facilities rather than use facility-based isolation rather than home-based isolation to protect family members and community members. So that's my answer to the adoption of this concept in other countries, maybe tailored to the specific context of each country. And yeah, for the second question, it depends on different, because there are 16 Fangcang shared hospitals in Wuhan that was built in February and March. So it also depends on different facilities their heads make the decision. But another thing is that the frequency of testing, PCR test for the health workers was not that frequently conducted. Comparing to the patients, because the health workers were protected really, really well. And when the disease, when the pandemic and the outbreak emerged in the United States, the health workers, they like most of them may not wear masks in the first place, but in China, we wear every health worker has PPE, so they are fully equipped and to protect them from getting infected. And I totally agree with Karina, like the science, like sometimes like in terms of this kind of emergencies, it's also very important to rely on your quick judgment rather than waiting for a comprehensive data set to be collected and to rely on science. Like in the United States, people are, like many experts were saying, there was no evidence to use masks because there were no evidence that masks can protect you from getting infected. But like in China, the idea, that judgment is like, we want to prepare for the worst because we want to quickly control this this epidemic, especially when this is a new virus and new outbreak. I think this is a lesson that I have learned, and also many of my colleagues have learned during the pandemic. Like judgment also important, especially when there is no time for us to wait for comprehensive data and science. So the health workers were protected really well. And so in the end, there were no infections for the health workers working in Fangcang shared hospitals. And they also, when they go back home, actually, it's also a special case in China because many health workers are not living in Wuhan. They were mobilized from like other provinces in China to help the Wuhan citizens to fight against the COVID-19 pandemic. And so they live in like also centralized places like hotels together. So they will not infect if they get infected, they will not transmit the virus to their family members and community members. They live in dedicated hotels when they finish work. But the good thing is, I think the most important thing is to protect health workers, especially during a pandemic, because these people, we need to protect them. Also considering to protect them safely and to prepare for the worst. And that's I think the most important thing for us to face a future pandemic when we don't know what virus it is. And so we want to prepare for the worst and help, and also safely to keep the safety of the health workers, because they are helping us and we rely on their lives.
Yes, it's true. Great. Thank you. Mike, do you think that because New Zealand has frequent hazards and has been vulnerable to past epidemic, this enabled better preparedness, or was it more agile response?
Yeah, so I think it was more an agile response. I know that Sean and his team were assembled pretty quickly, and similar to what Samir was saying, is you can't wait for the data or have a long modeling period. I mean, they built models with some estimated data in a week, and then the government acted on those models, and the government policy has sort of been refined as those models are refined. I do think that the recent hazards has probably made the government more receptive to responding proactively and quickly. So there's certainly, I don't think there was a sit back and wait and see response. I think the government was, well, we need to respond to this. So kind of so it's sort of an in-between answer. I think the particular COVID response was very agile, but I think the government had a proactive mindset, you know, possibly because of those previous hazards.
Yes, and also for you, for data science people, is it possible to have a model to foresee the presence of the next epidemics, the next outbreak?
I think that's tough. But so from my perspective, I think it's more about having systems that are agile and that are informed by data, and so there's constant monitoring of what's going on, right, and then you can start seeing those spikes happen. So that gets towards the early warning systems that Karina was talking about. And I think also even, you know, the idea of these shelter hospitals, like being able to really quickly put those mitigation steps in place. And I think China has been pretty amazing from my perspective from afar about that. So I think being informed by data, keeping track of what's going on, keeping a careful eye on things, and being, you know, prepared and agile, I think is the best we can do. I think it's very difficult to be able to determine when these things are going to happen, but I think being ready for them and using data science and using modeling to even just in the business as usual of health systems or other systems, I think is really important in terms of having a good response when things go wrong.
Yes, okay. I was thinking, because I have written something on this, Karina, early warning systems are well known for volcanic eruptions or for floods and things like this, and for specific geographic locations too. But something like an outbreak needs a global early warning system. In what kind of institutional context do you think that this could be done? On United Nations, or what kind of level?
Yeah, it's a good point. There's very few globally international warning systems that exist. I think the only truly global one is actually for volcanic ash, which is not very well known and not very well implemented. But of course, pilots don't want to learn 115 or different alert level codes. So
also maybe tsunamis.
Yes, but tsunamis, yes, like the Pacific Tsunami Warning Center is probably one of the most successful warning centers, engaged with many different countries. And so I think a lot's to be learned from those guys. And there's meteorite warning systems as well that of course are global. But I think, it requires a huge investment and in terms of money and buy-in by different nations. So I suspect that something like the World Health Organization or the UN would be needed on that scale to get that kind of interest and collaboration beyond each nation's political issues to really address the issues at heart. And so I think it would be wonderful to see those large organizations working with smaller groups and centers and to bring expertise to the table and examine that and implement it. I think that's probably where that will belong.
They are also the academy that works aside, and also the non-governmental groups. I mean, the private sector. There are many stakeholders there.
Yeah. Insurance sector, for example. Yeah.
I would like your opinion, maybe one or several of you. There is an interesting, it's a little bit long to read, excuse me for my English, but I think it's interesting. This comes from Mary Garay, and she said that about the design and planning of infrastructure, an alert protocol for preventive and corrective care of events similar to the current pandemics are being worked. They have activities and tasks under development, such as modeling in specific factual sciences. And she asks how much of safety factor in the preventive parameters of this design could be improved if we consider the factor of empowerment of activities like agriculture or water care at all levels of human groups in government policies. How much work is being done in this regard so that the contribution for future management has more impact and is more sustainable. It's quite large in the but maybe you may have a short opinion, everyone. Whoever.
Yeah, I'm just happy to give a quick answer on this. There are some organisations like Allfed, which is an NGO that is really trying to push the agenda of food security and agricultural and water security. And it's often an issue that's left at the bottom of the pile, which is astonishing because, of course, it's our absolutely fundamental need to survive to the next day. So I think how can we empower that? I think this pandemic hasn't necessarily given us an opportunity to see the impact of coronavirus, a disease on our food and water. Certainly in the developed world, probably more so in the developing world, if you forgive me for using those terms. But so I think in that sense, I don't think we're going to learn that much from this incident, but it is an important point. It will be one that will be particularly relevant in climate change.
Yes, okay. We are going through 2 hours now. I thank for your patience. And maybe a last question for Simiao, please. Our new member of the United Kingdom of the committee asks, do you believe the new way of living, working, brought by the outbreak of the COVID will have an impact in the way of designing the city of the future, where space will be more fluid and where people will use readapted to host new functionalities? Is it any way possible to also think as to how to make this infrastructure hazard resistant while being fluid in their use? Is there a balance?
So yeah, let me repeat the question. So if I understand correctly, so it's asking what lesson that for like to in the future, this kind of infrastructure, how can we leverage this experience in China to guide the future design of this kind of infrastructure to fight a potential pandemic? Yeah, I think this is a very good question. And actually, China has discussed, like the policymakers have discussed and outlined, drafted some guidelines and also launched some documents in terms of future preparedness for pandemic using these infrastructures. And previously, like this time, these infrastructures, some of them, because they were not used before to isolate patients, but in the future, there are, for public infrastructures, there are specific requirements for their, for example, ventilation system, because we want them during an emergency in the future, we want them to provide spaces for healthcare. And so they may have some design of the, for example, the ventilation system, and also like where to leave some spaces for example, restroom design, and also the door could be big enough to allow the quick establishment of the beds and other things to be built inside it. So this is it's actually integrated in the urban design. So it's not only about the health system, it's also about when you design a theater, when you design an exhibition center, when you design like other kind of public infrastructures, gymnasium, and yeah, so stadiums, like these public infrastructures, we also think about other functions when we design them. They may not, because this will not be the end of the pandemic. In the future, we may also face many unintended, unexpected emergencies, and in that day, on that day, in that situation, these kind of quick conversion between the original function to a healthcare function or a shelter function would be very useful. So it's actually integrated in the urban design guidelines for when we are designing and building these public infrastructures, to consider the ventilation system, restrooms, and other kind of changes.
Thank you very much. It is a great exchange among all of you. If any one of you would like to add something before any of the speaker or the panelists to before close our meeting.
Don Jose, I just would
Adelante,
like
Marcelo. Yes.
to recall an idea I told before. We have the same threat. It's the same COVID-19 in all countries, but we have different vulnerabilities. And I think Dr. Simao said Funcan shelters maybe not work in all countries because the vulnerability is different. Karina talked about the politics, and we know that not all politicians took the same decisions, and maybe there's a country that have great scientists, but the scientists don't take decisions. And it's just to add two more parts of what we have been talking. And what I want also to recall is that sharing information, what we are doing now, is so important. Knowing experiences, knowing what happened in our countries. It's not only saying, okay, open windows, because if you are in Russia, you are going to freeze. But if you are in Brazil, it's okay to open windows. You can't. It's not the same answer for everyone. So sharing experiences is great, and thank you for that.
Thank you very much. Okay, before give the place to Engineer Carlos Herrera from the Committee of Disaster Risk Management of the WFEO. I would like to thank you all, our outstanding speakers of today, and our guests, our panelists, as well as all of the participants in the room and in the Facebook. Also, not to forget to our technical support from the Colegio de Ingenieros. Thank you, Karim Salcedo, for the organization, and the technicians and the translator, to Lisette Lopez, our secretary of the committee, has been in permanent communication with all of you, and we are very, very happy and very proud of this meeting. We think that everybody has learned a lot. Please, Ingeniero Carlos Herrera, it's you to close this meeting.
Thank you very much. We have heard 3 accounts of how the pandemic has been successfully dealt with. We have seen also how the experience and knowledge gained in the exercise of an activity can be successfully used by analogy to face something little known that presents us new and different situations. But I think that above all, we have seen how technology and organization can be adapted quickly to deal with situations unknown to our former experience. All of us who have attended these important presentations and listened to that smart comments made by all the participants, I'm certain that we have learned and gained valuable knowledge. Then I warmly thank the speakers and the commentators for their input. Thank you very much to all, and good afternoon, good evening, and good night. Up the next time. Thank you very much.
Thank you. We have a photo of together, so we can pose for the photograph. If our technicians are ready, photo please. Liz, your camera for photo? No. Okay. Thank you very much and good day for all of you. And take care. Thank you. Thank you, Karina. Thank you, Simiao.
Pueden encender sus micrófonos para la
Goodbye.
despedida.
Goodbye to Ding.
Thank you very much. Have a good day.
You too. Thank you.
Bye. Bye.
Bye-bye.
Bye-bye. Thank you.
Goodbye.
Gracias, Marcial.
Mucho gusto, José. Muchas gracias por la oportunidad. Saludos.
Igualmente. Carlos, misión cumplida esta vez.
Muy bien, José. Realmente interesante, ¿no? Y deja un montón de preguntas. Yo iba a decir que nuestra experiencia había sido la otra cara de la medalla, pero prefiero guardármelo para mí.
Exactamente.
Es decir, todos hemos aprendido las experiencias exitosas y también de las menos exitosas como la nuestra, ¿no?
Sí.
Menos exitosas en una dirección de 180 grados.
Pero la cuestión es si es que hemos aprendido, porque eso de lecciones aprendidas, una de las últimas conferencias que hubo sobre justamente gestión de riesgo de desastres, ¿no? En el colegio justamente, con el grupo de desastres. Alguien decía, siempre hablamos de lecciones aprendidas, pero la verdad es que aprendemos o no, porque esa es una canción conocida